Patient selection and eligibility guidelines. Proper patient selection is vital to a successful outcome. Some patients will likely be dissatisfied regardless of the surgery result. This emotional dissatisfaction often supersedes technical failure as the most common cause of poorly perceived results. The surgeon must be thorough in the initial evaluation to determine whether the patient is psychologically and physically stable enough for surgery. Gunter and Gorney have both commented on danger signs that may be exhibited. Individuals who meet these criteria should be approached with caution because surgical intervention may not be in the best interests of either the patient or the surgeon. These criteria include minimal disfigurement, delusional distortion of body image, identity problem or sexual ambivalence, confused or vague motives for wanting surgery, unrealistic expectations of change in life situation as a result of surgery, history of poorly established social and emotional relationships, unresolved grief or currently in a crisis situation, present misfortunes blamed on physical appearance, older neurotic man who is overly concerned about aging, sudden dislike for one's anatomy, especially in an older man, a hostile, blaming attitude toward authority figures, history of seeing physicians and being dissatisfied with them, indication of paranoid thoughts. Gorney employs two systems to identify potential problem patients. The first uses the acronym SIMON, single immature male overly expectant, narcissistic, to describe certain worrisome traits. The second plots the patient's concern against the degree of deformity. Patients who have an appropriate level of concern relative to their degree of deformity are excellent candidates. Those who have minimal deformity and a disproportionate level of concern should be avoided because their expectations may exceed the amount of aesthetic improvement possible. Ideal patients are secure, emotionally stable, well-informed, and understanding of the limitations of rhinoplasty, and realistic in their expectations. The acronym Sylvia describes the appropriate female rhinoplasty patient who is secure, young, listens, and is verbal, intelligent, and attractive. The surgeon must be cautious when working with patients at the extremes of the age spectrum. Rhinoplasty is generally delayed until the age of 15 for females and 17 for males, when puberty is complete and the nasal anatomy is not expected to change or grow appreciably. Parents should be present, but some time alone with the patient can be informative in terms of assessing motivation and illicit drug use. Primary motivation should come from the patient and not the parent or through parental pressure. Moreover, social pressure as the primary motivating factor will likely be deemed unsuccessful. Elderly individuals seeking a rhinoplasty also represent a unique demographic. While their nasal deformity may be obvious, the patient has lived with it for their entire lives and it has become an integral part of their subconscious identity. Unlike new-onset wrinkles or aging features, the nasal appearance has always been present and something they see each morning in the mirror. Altering this may impact their self-image in unpredictable ways. The psychological impact of a dramatic change can be enormous and the rhinoplasty surgeon should proceed cautiously and perform only conservative changes. Anatomically, these patients may present with thinner skin, fragile nasal bones, and weakened tip support mechanisms. These abnormalities may affect the surgical approach, such as performing more limited osteotomies or focusing on tip support. One of the fundamental steps in the preoperative activity prior to rhinoplasty is the creation of a detailed and personalized treatment plan. The ideal treatment plan must respect the wishes expressed by the patient, the morphology of the patient's face and nose, initial conditions, nasal function, the abilities of the surgeon himself, who must feel comfortable carrying out the procedure that he is doing for the good of his patient. No rhinoplasty patient, male or female, wants to look overdone or artificial after rhinoplasty. The goal of rhinoplasty is to enhance the appearance of the nose, not radically change it. Men generally want a strong, straight nose with a higher bridge and larger nostrils than a female nose. Men are more likely to need rhinoplasty after a nasal injury from a sports accident or a fight. Women generally prefer a more petite nose with slightly more upward rotation at the tip, but not so much that the tip is upturned or creates a ski slope effect. Most women want a slim bridge and delicate nostrils. Women are usually very conscious of how their nose balances out their facial features, and often wish to adjust the proportions of the nose so it does not look oversized compared to the rest of the face. Finally, to start, the surgeon needs to know the most important aspects of nasal appearance that the patient wishes to change. The surgeon must agree to include the patient's wishes among the vital few points. A failure to obtain these absolutely necessary objectives, vital few, invariably leads to postoperative patient dissatisfaction despite the many other goals that have been reached, trivial many. Operative techniques. There are two schools of modern rhinoplasty: endonasal or closed approach, and extranasal or open approach. While both approaches have their advantages and disadvantages, it is important to be familiar with both. Regardless of the approach, however, the modifications made to the underlying framework are more important than which incision is used. Experience and comfort of the surgeon performing the rhinoplasty will play a large role in the surgical approach. Additionally, the amount of tip surgery required may sway the surgeon's decision for a particular surgical approach. Suits fine to patients who have an isolate dorsal hump deformity or where there is minimal change needed to modify the tip structure. In cases requiring minor tip refinement, an intercartilaginous incision allows adequate exposure. A hemitransfixion or transfixion incision is used if the caudal septum requires repositioning. Advantages of endonasal rhinoplasty: leaves no external scars, limits dissection to area needing modification, permits creation of precise pockets so grafts fit exactly without need for fixation, while preserving patangui ligament, promotes healing by maintaining vascular bridges, produces minimal post-surgical edema, reduces operating time, and fast patient recovery. Disadvantages of endonasal rhinoplasty: requires experience and great reliance on accurate preoperative assessment. Since there is limited access and view of the nasal framework, this could imply less precision. Prohibits simultaneous visualization of surgical field by teaching surgeons and students. Difficult dissection of the alar cartilage, particularly in case of malposition. Although less invasive, closed rhinoplasty is not used for reconstruction or complex nose surgery. It is frequently indicated in primary rhinoplasty with minor changes. Many experienced surgeons prefer the open approach. It provides better exposure of the nasal framework. The open approach is particularly advantageous in the following circumstances: post-traumatic deformities, revisional surgery, and when complex tip modifications are necessary. Advantages of extranasal approach: binocular visualization and better access to the nasal structures. Proper analysis of the anatomy and make better decisions. More options with original tissues and cartilage grafts. Direct control of bleeding with electrocautery. Also, open rhinoplasty approach is far well known and practiced by most surgeons. Disadvantages include invasive approach with external nasal incision, transcolumellar scar. Prolonged operation time and slower recovery period. Protracted nasal tip edema. Delayed wound healing. Preoperative care. By this I mean the sequential steps between deciding to program the rhinoplasty and beginning the actual surgical operation. In preparation for the operation, it is useful for the patient to have a list they can check from time to time. 2 weeks before surgery. Do not take aspirin or other drugs containing acetylsalicylic acid within 15 days prior to surgery. Do not take NSAIDs, vitamin E, or herbal supplements or medications within 2 weeks of your surgery. Specifically, herbs may disrupt how anesthesia works. Stop all nicotine products, including any tobacco products, vaping, or nicotine patches, since nicotine decreases circulation and may result in a poor outcome. Start vitamin C 1000 mg 3 times per day to improve wound healing. 1 week. Do not drink alcohol for 1 week before and after surgery. To avoid cancellation, all lab results and testing is due. If you color your hair, it should be done 1 week before and/or 5 weeks after surgery. There is a chance that surgery would be cancelled if you have active acne. Day before surgery. For men, remember to shave beard and mustache the day before the surgery. NPO, including water and gum chewing, for 6 hours prior to operation. The only exception is medication, which we will instruct you to take the day of surgery if needed, with a sip of water. Day of surgery. The patient may shower and shampoo the morning of surgery. Do not wear makeup or use hairsprays/gels or flammable cosmetics. Don't wear contact lenses. If the patient has menses, advise to wear a feminine napkin, not a tampon. Xylometazoline nasal spray is used for septal mucosal vasoconstriction. Using the spray 30 minutes prior to surgery ensures a bloodless septoplasty and decreases the systemic absorption of septal injections. It also eliminates the need for intraoperative use of nasal packings with adrenaline. Patient position. The patient is positioned in a reverse Trendelenburg position, with the head extended 20 to 30 degrees so that it is parallel to the floor. This position allows the hip to be in the lowest position and decreases blood pressure in the head. Keeping the head parallel to the floor decreases the likelihood of making rotation errors. The patient's chin should be visible and kept in the visual field. This will provide more substantial control. The tube is positioned away from the surgeon at a 45 degrees angle. Be sure that the intubation tube does not pull on the lips. If the tube is positioned in the midline as a reference point, it can slip and mislead you. The pressure of the intubation tube is measured throughout the surgery. This decreases sore throat after surgery. Interposition of a small gauze between the endotracheal tube and the lower lip to protect the latter. The head of the patient on the operating table should be parallel to the floor. If you do not keep the position of the head at this angle in every operation, your chances of making a mistake increase. Cleaning. Nasal vibrissae are better removed with a blade. Applying povidone iodine will ease gliding the blade on the mucosa. Do not struggle with applying ointments or using scissors. Before doing anything on the patient, better wait until the systolic blood pressure drops below 90 mm of mercury and the pulse rate below 80 minutes. Anesthesia. Rhinoplasty can be carried out under either local or general anesthesia. The goals for appropriate anesthesia are amnesia, analgesia, sedation, and a dry operation field. The advantages of a general anesthetic are complete amnesia, analgesia, and sedation, but a disadvantage is the often far from bloodless operation field. There are 3 primary types of anesthesia that can be used during a rhinoplasty procedure: local anesthesia, for sedation, and general anesthesia. The complexity of the cosmetic surgery, the patient's comfort, and the preference of the surgeon are factors that determine the choice of anesthesia. Nasal local anesthesia. The 3 main objectives of infiltration with local anesthetic are all necessary in nasal surgery. The sensory block, which must be maintained during and beyond the operative time. Vasoconstriction, necessary for reducing intraoperative bleeding. Hydrodissection, which helps in finding and maintaining the right dissection plane during flap elevation. Surgeon's preference should be taken into consideration while preparing the infiltration solution. Example. For the nose, 20 cubic centimeters, composed of 9 cubic centimeters isotonic saline, 10 cubic centimeters mepivacaine HCl, 1 cubic centimeter 1/4 adrenaline. With this composition, this solution contains 1/80,000 adrenaline. For the septum, the solution prepared for the nose is used at a 1:5 dilution for the septum so that it contains 1/400,000 adrenaline. Injections to the septum can act like an 4 injection. Therefore, we prefer low concentrations of adrenaline and a small volume of injection. The most commonly used needle is the 30G 0.3 by 21 mm. Every single infiltration must be very small in order not to deform the soft tissues too much and change the original shape of the nose. The solution is injected by slowly retracting the needle. Apply the solution very slowly. The injections usually take 10 minutes. Follow the pulse rate and EtCO2 pressure while injecting the solution. There is no need to give extra injection during the surgery. A bloodless surgical field for 2H can be obtained with the injections. Specifically, the 5 areas for injection consist of 1. Tip and columella. 2. Lateral wall. 3. Dorsum/extramucosal tunnels. 4. Incision lines, and 5. Septum. Injection points. Both sides of the caudal septum. Into the planned incision sites for tip surgery and over the lateral crura. The internal nasal valve. The area of the anterior nasal spine and the inferior margin of the piriform aperture. Dorsum of the nose. Injecting below the perichondrium starting from the septal angle eases subperichondral dissection. The radix area is instead infiltrated with a direct transcutaneous approach. Ideally, 0.4 ml of solution is injected deeply, keeping the needle in close proximity to the periosteal plane. Injection along the lateral wall of the nose over the nasal bone and upper lateral cartilage. Over and under the piriform aperture. The internal nose and the whole face are prepped with povidone iodine solution. Finally, stick a transparent tape over the mouth to keep your little finger and the sutures from contacting the inside of the mouth. Now, your patient is ready for operative intervention. After taping and splinting the nose at the end of the surgery, an infraorbital block with 1 cc solution increases post-op comfort of the patient. Do not inject too much. This can result in a loss of surface details. You should be aware of the side effects of local anesthetics. A total of 5 to 7 cubic centimeter solution should be sufficient. During the dissection of the nasal dorsum, there can be bleeding from bone, which is usually venous and difficult to control. Injection into the mucosa underlying the bone can decrease bleeding. Do not point the surgical lights directly on the nose, otherwise you will not see the details.